We looked at our in-hospital interventions of our rapid response team. That's mean the team who goes if a patient is in a critically situation, and our focus was especially for in-hospital cardiac arrest. We had a look at our data of the last 4.5 years. And the special focus was on cardiac arrest associated with gasping, so with agonal respirations, and the association we found between them. And on the other side, with cardiac arrest and happening during the day and during the night, so if there is a difference or not. So we found that cardiac arrest happening at our teaching hospital during the night had less favorable neurological outcome, and this was most probably due to a delay in the recognition of the cardiac arrest during the night. We found that during the night there were less shockable rhythm recognized, which have a better prognosis shockable rhythm. So with a less less shockable rhythm during the night, we have also a worse neurological outcome. And we also found that during the night there were less witnessed cardiac arrest. That means less people see that something happened, less good rhythms, and altogether brings to the conclusion that during the night we had a less a worse neurological outcome from our patients. The problem is that only in approximately 1/3 of the patient, or 1/3 of the patient was lying on a monitored bed. So only 1/3 of the patient, only in those patients the cardiac arrest could be recognized very quickly, and 2/3 were lying on the normal ward where the patients are not monitored. So for those patients it was really important that a nurse was around, or doctors were around, and during the night, or even just relatives from another patient were around, just that somebody was around. And during the night there is for sure less or fewer people around. Yes. It's difficult to change something, because from the economical point of view it's difficult to say, okay, just increase the people working at night of 10–15%. We don't have a recipe at the moment how we can change something. That was just what we saw looking at our data, and other hospitals have shown the same results during the night. We can be happy on one side because we didn't see any difference, for example, between weekdays and weekends. So that was not a difference, but during the night it's still a problem. So one possible solution I've heard from other experiences in other hospitals is to keep a better track of the patient's conditions during the day, and a standardized condition, and maybe through these standardized conditions we can better see which patient is getting worse and which one is not getting worse, and maybe then be more sensible on those patients who are getting worse, and maybe prevent some cardiac arrest. I think it's if we want to organize something like that, it's the hospital who has to decide it first, and then improve it and make some rules that nurses, or some organizational changes that this system can be improved. We can't say that our solution is the solution solving all the problems. I think we need to discuss it to see what is feasible, what not. We can't change the situation that at night there are fewer people working at hospitals. So we can maybe adjust something, but big changes, I think it's difficult to achieve. I think for sure, if we manage to have a better idea of which patients are getting worse, that would help in all the situations and all the wards. For sure, we could prevent situation that at the end comes to a cardiac arrest, but that means that even other conditions can be prevented. I mean, that's for sure a global issue, but I don't think that our study would change. Firstly, we were not the first ones who showed those data. We were interested to see how the situation is in Switzerland, and but it's for sure a topic which can be interesting for many hospitals, many countries, for everywhere.